Good afternoon, everybody. Today we will talk on a very common symptom which is seen in children, that is the pain in abdomen. Children come up with pain in abdomen as a symptom where the parents are really worried. The child himself is very uncomfortable. It might be a very vague pain, it might be a specific pain. The pain might be making the child very unbearable. All these things are possible, and because of that pain the parents and the child both become quite anxious, and they want to get relieved of this pain. When they come to a pediatrician, it becomes difficult for the pediatrician because the child in most of the cases is unable to exactly pinpoint or locate the pain in abdomen or the point of maximum pain. And depending upon the history and clinical findings, the the doctor has to, or the pediatrician has to exactly find out the most probable or pinpoint the exact cause for pain in abdomen. So looking into this clinical differentiation, we are going to talk in this lecture about clinical differentiation diagnosis of pain in abdomen. I would divide this lecture into two, where in the first part we would talk about the pain in abdomen which incurs because of the GI pathologies and other abdominal pathologies, whereas in the second part we will talk about the non-abdominal causes which lead to abdominal pain. That means those are causes other than the GI tract involvement or other than the intra-abdominal organs involvement, which will lead to a referred pain to the abdomen. And also in that second part, we will talk about the Ayurvedic diseases where we are going to have this pain in abdomen. So as I have already spoken of, pain in abdomen is a common symptom which comes up with many systemic disorders. And if we try to classify them under the specific systems, the first and the foremost system which is responsible is because of the gastrointestinal pathologies. The gastrointestinal pathologies are going to create a very common symptom, or most of them, I would say every other gastrointestinal disease uh, presents itself with pain in abdomen. The second common system which gives a symptom of pain in abdomen is the urinary system. Though the kidneys are extraperitoneal, though the bladder is extraperitoneal, still the pain is felt in the abdomen. Similarly, genito-reproductive system gives up a specific and a localized pain which we need to discuss of. Then there are some other abdominal causes where the pathology is related to the liver or the spleen or the omentum or the peritoneum. Then there are respiratory diseases where the pathology is in the lungs and we feel the pain in the abdomen, the upper abdomen. And we have some other diseases or other causes like we have something known as abdominal epilepsy, we have something known as abdominal migraine or psychological pain or functional pain, and all those things which we need to talk about while, or which we need to think about while considering the situation of pain in abdomen. If we go to Ayurvedic part, again here, pain in abdomen, what will be called as Udarshul, is seen in quite a few diseases. They are Shula Vyadhi, then we have Parinam Shul, which is related to the GI tract, Ajirna and Agnimandya, Amlapitta, Krumi, Grahani, Gulma, and Vidradi. Of these, most of them they are related to the GI tract, whereas some are also present in the other disorders also. So if we go for the gastrointestinal diseases, the first one, the gastrointestinal diseases, the commonest part, the first and the foremost disease which gives rise and which is very common in children, which leads to pain in abdomen, is constipation. Childhood constipation is typically characterized by infrequent bowel evacuation, large stools, or and difficult or painful defecation. It is one needs to understand that constipation is not passage of stools. It is one part of it is not passing the stools adequately or on time. So it is characterized by infrequent bowel evacuations. The span between two bowel evacuations is a bit much larger span than what it should be. Then secondly, the amount of stool passed is more. They are hard, which causes most of the pain, because most of the time because in as the stools stay for a longer time into the large intestine absorbs water, fluid, and electrolytes from the stool material, from the undigested material, making it more dry and hard, and therefore they become hard stools. And it is because of these hard stools that we get a difficult and a painful defecation. We need to strain so as to pass the stool, which creates more and more problems and which needs to be addressed. And therefore, because we have to strain, we might get pain in abdomen. Again, because of pain in abdomen, we might get constipation. So that becomes a cycle. And this hard stool, while passing out, they put up a pressure on the anal sphincter, which causes painful defecation. Now, when can we say that this pain in abdomen is because of constipation? We need to take a very clear history of the diet of the child. Typically, a child eats a food with low fiber contents. He would give you a history of eating more of starchy foods. He would give you a history of more of fatty foods, but less of fiber foods. He will eat a low fiber diet, or he might even have a low amount of that, a poor nutrient intake. He might give you an history. The child might be malnourished, and because he is not getting adequate food, he will not be taking adequate amount of food. The volume of food would be less, and also you might get a history of low intake of fluids. Water intake would be low, and therefore the stools would become hard. So we need to take a very proper history of diet when the child comes up with pain in abdomen and we think of constipation. So history makes a major point when we are going to diagnose constipation. That is the dietary history. The child tends to develop during three stages of this pain tends to develop during three stages of childhood. The first time when this pain might come up because of constipation, or constipation might come up first of the time during the weaning period, where when the mother is breastfeeding, the child passes stools frequently. In the initial days, we have something known as the gastrocolic reflex, where the child has breast milk and immediately it passes stools. That is the gastrocolic reflex. So the passage of stool is frequent. But once we start introducing to the child the top feeds other than breast milk, then the child is going to drink less of water, is going to receive less of water, because breast milk was having ample amount of water. So during weaning foods, we are going to have constipation as the first thing. Then, while we go for toilet training, the children are not willing to go for toilet on their own, and when we try to go for toilet training, the children would forcibly try to arrest the passage of stool. And this is during the toddler age, when we are try to tell them, when we try to teach them how to go for toilet, how to sit for toilet, how to pass the toilet, and how to clean it. The children, they don't want to do that, and therefore there might be forceful or uh, voluntary arrest movement of passage of stools that would lead to constipation. And the third time during school, that is the older children would constipate because they go to school, they have not passed or they have not evacuated at home. They might get a feeling of passage of stools during the school hours, and that might embarrass them to ask the teacher whether they can go to pass the stools, or their friends might keep on teasing them. That creates a sense of insecurity and a sense of embarrassment. So they might arrest the passage of stools, and that would lead to constipation. Now, when a child has constipation, the pain in abdomen will be very vague. The child will not be able to pinpoint the exact site of the abdominal pain. That will be very vague. Secondly, along with pain in abdomen, a vague pain in abdomen, the child would say, or the parents would say, that he does not pass stool because he says it's paining at the anus. That means the child is going to have painful defecation. In infants, the legs may extend, the infants may extend their legs and squeeze anal and buttock muscles to prevent stooling. Infants might throw tantrums also, and they will keep on extending down their leg. They don't want to pass the stools. They want to arrest the passage. That is because of pain, or they don't want to do it voluntarily. In any case, to squeeze the anal sphincter, they will extend their legs and contract their buttocks so that the anal sphincter is contracted. The toddlers often rise up to their toes, shift back and forth, and stiffen their legs and buttocks. When they have that pain during defecation, or when they have that pain during constipation, they want to clear out the stools. The toddlers feel uneasy, and they would often rise up to their toes. They would stand on their toes and raising the heels, and they might shift back, they might bend forward, they might bend backwards, they might move forward, they might move backward, and stiffen their legs and buttocks to show that they have stools coming up, but they are constipated, they are paining, or they are trying to voluntarily hold that, and then the pain in abdomen starts up. There will be minimal or no abdominal tenderness. There will be absence of guarding. Guarding is a abdominal sign which is indicative of tenderness or immediate inflammation below the point of palpation. So in constipation, there is no infective pathology going on. There is no abdominal tenderness because of absence of infection or absence of inflammation. So there will be no guarding. And once there is no guarding, there will be no rebound tenderness. Therefore, there will be minimal abdominal tenderness, absence of guarding or rebound tenderness, and the child will have severe abdominal distension. This is very much possible because along with the fecal material, the flatus will be arrested in the large bowel. So there will be lot of amount of distension of the abdomen of the child. If the child is very lean and thin, then we might be able to pass fecalith, that is the fecal mass, which might be possible to be palpated. Even sometimes a fecalith might remain into the rectum, and if we try to go for a rectal examination, we might palpate the, or we might feel the presence of a fecalith. The second common disorder with pain in abdomen is the intestinal worm infestation. Worms are very much common, and they come up because of unhygienic condition or unclean food eating habits, or functional disorders of the child, where the child keeps on biting his nails, or he tries to eat mud, that is he might have pica and all those things, and then the child may get a intestinal worm infestation. So worm infestation is the second most common disorder where we find pain in abdomen. In worms, the pain in abdomen is not continuous. It is recurrent. It comes up, then it might stop for some time, and again it might come up. Again, this is recurrent pain, and similar to that of constipation, it will be a vague or a diffused pain. It will be felt all over the abdomen. You cannot pinpoint the place where you have pain in abdomen. Therefore, there will be a diffused pain. Then, thirdly, we have something known as failure to gain weight because the worms are going to eat up all the nutritious material what the child is going to take from the food. So the child will not receive nutrition. So it is a saying that worms deprive the child of its blood and its nutrition. So the roundworms, they are going to deprive the child of the nutrition, and the roundworms and the hookworms, they are going to deprive the child of their blood. So because the nutrition is taken up by the worms and the child is deprived of adequate nutritious food, then the child will fail to gain weight. Then there might be a history of change in bowel habit, like the child was passing stools at a specific time daily, say in the morning or in the afternoon. The time was practically fixed, but at all of a sudden there has been a change. Sometimes he passes in the morning, sometimes in the evening, sometimes he might be constipated that way, or even there might be a change in the bowel habit, like in the form of consistency of stool, that they might sometimes get hard, they might be soft, they might get unformed, there might be unformed stools, they might be foul smelling, they might be non-smelling. All these types of changes can come up in the stools. Then the child might also have an altered appetite. The child will have voracious appetite sometimes, and sometimes it will have a very poor appetite. So there will be alteration in the dietary habits, there will be alteration in the bowel habits, and there will be failure to gain weight. Then the third common disorder where which we have pain in abdomen, again because of the GI tract, we have gastroenteritis. That is the inflammation of the GI tract. It might be the gastrum alone, it might be the intestine alone, or it might be the inflammation of both of them. In gastroenteritis, the pain is typically of cramping type. There are cramps which come up because of the involuntary contractions of the involuntary muscles of the abdomen, and because of that there is contraction of the anterior abdominal wall also, so there will be cramps, what we say as, in the abdomen. There is no guarding and cramps is a different issue. Though there is inflammation in the GI tract, there will be no tenderness, there will be no guarding, there will be just cramps in the abdomen. And this pain in abdomen is associated with fever, vomiting, and diarrhea. So a child who presents himself with pain in abdomen, with fever, vomiting, and or diarrhea, with cramps in abdomen, we should first think of gastroenteritis. Cramps are very much equatable with gastroenteritis. Then if we go to take a history of the child, we will find a history of recent travel or contact with a sick individual, or ingested ingestion of suspected food and drink. The child or the parent might give you a history that the child had eaten food outside than the homemade food. It might be because of travel reasons, or it might be because of going to someone else's place, or he might have had eaten the market food which was not of the good quality. So again, you will have this history over here. There will be abdominal distension because the child will be losing potassium through the vomitus and the stools, and therefore he might have paralytic ileus leading to abdominal distension. Again, sometimes uh, abdominal distension comes up because of bloating also. Sometimes there will be no abdominal distension and we will have hyperactive bowel sounds. That will be, there will be exaggerated peristalsis. The peristalsis will be more. And along with that, Presence of signs of dehydration like the sunken eyes, sunken fontanelle or the depressed fontanelle, dry skin or loss of skin turgor, oliguria, excessive thirst, all these signs of dehydration will be present in case of acute gastroenteritis. Now one has to remember that acute gastroenteritis is always infectious. But if a child comes up with diarrhea or gastroenteritis which is more than 10 days old, then remember that gastroenteritis is mostly because of parasites, or it is mostly of the origin of a non-infectious cause. Then of this gastroenteritis, if we talk of acute gastritis, the pain, if you ask the child where it is a sharp pain, not throbbing pain, but it will be a sharp pain, really a bad pain the child might feel, and he will be able to pinpoint that pain and tenderness at the epigastric region. You will feel, the child will say, or he will pinpoint it with his fingers that the pain is in the epigastric region, and when you try to palpate the abdomen in the epigastric region, there will be tenderness and some amount of guarding. A sensation of pressure and fullness is there with the child, which intensifies after food ingestion. That means when the child says that he eats the food, he feels that the stomach is full even with small amount of food. There will be belching along with pain in abdomen, and after belching out, the child will feel a bit relieved of the symptom. And in gastroenteritis, you have nausea and vomiting. Most of the time, it would be a foul smelling. Then another abdominal or the GI tract disease which can lead to, or which can come up with a symptom of pain in abdomen is appendicitis. This can occur in all groups. I'm talking about acute and acute on chronic type of appendicitis. Appendicitis can occur in all age groups, but it is very rare in infants. So, smaller children, younger children, older children, adults, all can have appendicitis. Even infants can have it, but it is very, very rare in infants. The pain in abdomen is sharp or stabbing. Then the pain is felt in the periumbilical region that migrates to the right lower quadrant. Now, pain in abdomen in appendicitis is really very sharp. The child is inconsolable during the attack of pain. It is so sharp. And the pain in abdomen, generally, if the location of the appendix is in the right lower quadrant, just below the cecum, then it will be felt at the periumbilical region and then migrating towards the lower quadrant of the abdomen, right lower quadrant. The site of pain would change with the site of presentation of appendix. If the appendix is retrocecal, you are going to feel the pain at other sites. If the appendix is paracecal, you are going to get the pain in other sites. So all, it depends on the site, but there will be a sharp stabbing periumbilical pain initially. Then the child might have severe vomiting and fever associated with pain in abdomen. Then the child might have even diarrhea, and the child might have anorexia with, in the case of appendicitis. So a triad of pain in abdomen, fever and vomiting should give a rise of suspicion towards appendicitis. When during the pain, because of the severe intensity of the pain, during the episode of pain, the child will lie still. It doesn't want to move because during the movement, the child will get more pain, and when he lies still without any movement, there is no irritation of the surrounding tissue, surrounding masses, and therefore the pain will be relieved somewhat. So during the attack of pain, during the episode of pain, the child will lie still. Then, depending upon the position, we have different types of signs which can be seen in appendicitis. The child will have positive McBurney sign, which is a common sign in appendicitis. You feel the pain or the point of maximum tenderness in the right lower quadrant at the McBurney's point. That is the point and on an imaginary line between the anterior superior iliac spine and the umbilicus. So there will be severe tenderness and guarding at the McBurney's point, that is called as positive McBurney's sign. So this pain is felt in the right lower quadrant. Then we might have positive rousing signs if the umbilical, if the appendix is irritating or touching the peritoneum. We get a rousing signs. The rousing sign is elucidated by pain in the right lower quadrant in response to the left-sided palpation. When you try to palpate the abdomen on the left side, the peritoneum will move over the inflamed appendix and it will give a sudden rise to a sharp pain, that is known as positive rousing sign. Then if the psoas muscle is irritated, the fascia is irritated, then we are going to get a positive psoas sign. The psoas muscle arises from the abdomen, and when it gets and is covering the or is the part of the lower abdominal wall, the internal side of the abdomen. So when that is getting irritated, you are going to get a positive psoas sign. The psoas sign can be elucidated by seeing the pain in the right lower quadrant when the child is placed on the left side and right hip is gently flexed. When you flex the right hip, the psoas muscle will get relaxed and it might get irritated because of the appendix, and therefore there will be irritation of the psoas fascia and the muscle, which will give rise to a instant severe pain. So that is known as the positive psoas sign. Similarly, if the obturator muscle is irritated, we might get a positive obturator sign. Now what is the obturator sign? There is pain in the right lower quadrant when we flex the right thigh and move it or rotate it internally. At that time, the obturator muscle might get irritated, and that will be considered as a positive obturator sign. And when we go for a per rectal examination, sometimes we might find a palpable abscess in the right lower quadrant, or we might find, when we go for a per rectal examination, we will find rectal tenderness, and if we try to palpate from the abdomen, we might get a palpable abscess in the right lower quadrant. It depends on how much infection and inflammation has occurred during the pathogenesis of appendicitis. So when we see or when we have a patient with appendicitis and a pain in, when we suspect appendicitis in the case of pain in abdomen, then many of these signs should be present. Pain, vomiting and tenderness at the periumbilical region should invariably be present. The child might stay still. We might have any of these signs positive, one or multiple, the McBurney sign, the psoas sign, the Rosing sign, or the obturator sign. Similarly to that of appendicitis, we have one another pathology known as the Meckel's diverticulum. This Meckel diverticulum, if it gets inflamed, it is going to give rise to pain in abdomen. This inflamed diverticulum is called as Meckel's diverticulitis. In this picture, you can see the Meckel's diverticulum, an extended pouch on the intestine, the small intestine. So this is known as the Meckel's diverticulum, and when this part gets inflamed, it is going to show you signs similar to that of appendicitis. Now this Meckel's diverticulitis is generally seen in children below 2 years of age. Appendicitis was seen in any age, whereas Meckel's diverticulitis is common below 2 years of age. The pain in abdomen will be similar to that of pain in appendicitis, but it may be intermittent or it might be similar to that of severe as appendicitis. So the difference between making a difference between appendicitis, when you have pain, vomiting and temperature, you need to look first at the age and the time at which you are going to get the pain. The age factor, appendicitis is common in any age, rare in infants, whereas Meckel's diverticulum is common below 2 years of age, rarely in the older children. And the character of pain, in appendicitis, it was a continuous sharp pain, whereas in Meckel's diverticulitis, it might be a it is mostly a intermittent pain. Then we had not seen any passage of blood through the along with the stools in appendicitis, whereas in Meckel's diverticulitis there will be painless passage of bright red blood through the stool or per rectum, which is called as hematochezia. So there will be passage of blood through the rectum, which is painless. Also, you might get dark red, maroon, red currant jelly stools, which is common with intussusception also. So we need to differentiate Meckel's diverticulitis with intestinal intussusception and the appendicitis. And there is abdominal tenderness and guarding and rebound at the site of the inflammation at the site of the diverticulum. Now we have seen a common symptom of pain, vomiting and tenderness or temperature in appendicitis and in Meckel's diverticulitis. Now we have a common symptom of red currant jelly stools in Meckel's diverticulitis and in intussusception. Intussusception usually occurs in infants between the age of 3 to 12 months of age, and this is maximum seen in the age group of 5 to 7 months. We have seen the age group of Meckel's diverticulitis as below 2 years, and intussusception again below 1 year is it is common. It can occur in older children, but it is common below 12 months of age. Intussusception should be suspected in an infant in this age group presenting with severe colicky abdominal pain, flexing of the legs so as to relax the abdominal muscles and reduce the pain, because when you extend the legs, the abdominal muscles are stretched out and the pain might increase. So if you have to relax the muscles of the abdominal wall, you need to flex the legs. Then there will be lethargy, vomiting and fever in intussusception. There will be vague abdominal complaints and there will be severe cramp-like abdominal pain, much more severe cramps than that what we had seen in gastroenteritis. So there will be severe cramp-like abdominal pain in the abdomen. There will be severe abdominal tenderness at the site of intussusception, and we will have palpable mass, abdominal palpable mass at the site of intussusception. The shape is generally like that of a sausage what we have in a hot dog. It's an elongated, firm mass which can be palpated. That is because two intestinal loops enter each other, the intestinal loops enter each other, making it a firm mass palpable. So like a hot dog sausage, we will be able to palpate a abdominal mass. Because the pain is severe, the child is inconsolable, and gross or occult blood may be mixed with mucus and may have red currant jelly appearance. So, intussusception and dehydration we have to differentiate. That we have a common pain in abdomen, cramp pain in abdomen, but in dehydration we are going gastroenteritis we are going to have dehydration signs, whereas in intussusception we are not going to have dehydration. We have to differentiate intussusception with diverticulum and intussusception because we have red currant jelly stools. In diverticulitis, there is going to be pain similar to that of appendicitis. In intussusception, it will be a severe pain with an palpable abdominal mass. Then we have another one, that is the intestinal obstruction, small bowel obstruction. Intestinal obstruction can occur up with small bowels and large bowels, both. So, we are going to talk first about the small bowel obstruction. The abdominal pain may not occur until obstruction has progressed to include extensive abdominal distension or intestinal ischemia. If there is a small obstruction, there will be mild pain or there might not be a feeling of pain. But when the obstruction reaches to a level where ischemia develops or ischemia has set in or there is severe distension of abdomen, then only pain in abdomen will be seen. So if you have pain in abdomen and a finding on X-ray or ultrasound that you have got intestinal obstruction, remember that the disease has progressed to a far extent. There will be intolerance of feed. The child will keep on vomiting, and that will be a severe vomiting. That will be bilious vomiting. There is severe pain in abdomen and tenderness. There will be limited abdominal distension. The site of obstruction, above that site of obstruction, there will be distension, and below that site of obstruction, there will be collapse of the intestine, because at the level of obstruction and above over that, the food, the fluids, the liquids, the gas, everything would be stagnated. So there will be limited abdominal distension with proximal obstructions in the duodenum or early jejunum. But if it is beyond that, then above all that you will find the signs of distension. There will be rebound tenderness, and guarding may occur with perforation, ischemia, and peritonitis. Above the level of obstruction, there will be hyperactive bowel sounds, and below the level of obstruction, there will be absent or low hypoactive bowel sounds. But these bowel sounds are felt only in the early obstructional stage. Once obstruction is complete, or once obstruction has made I would say a deep impact, the bowel sounds disappear. So in early finding, in early obstruction, hyperactive bowel sounds is a finding, whereas in late obstruction, they might be absent. In case of large bowel obstruction, in children who have large bowel obstruction, we will get a history of painful bowel disease. Inflammatory bowel disease, or means the child might be suffering from celiac disease or some other kind of inflammatory bowel disease, or we might have a history of previous colorectal resection because of any reason. There might have been a history of abdominal operative procedure of the GI tract. We might get a history of laxative abuse. The child was constipated and he was being given continuous laxatives which can cause intestinal obstruction. Then we might have a condition known as the megacolon, which is either congenital or acquired, or we might even have a previous abdominal surgery where the nerve settings have been damaged and which can cause obstruction. Now the pain in abdomen in a large bowel obstruction is colicky, and it worsens with movement, coughing, or deep breathing. The more you deep breathe, the more abdomen is going to get inflated. It will put up a pressure on the large bowel and there will be more of pain. So with deep breathing or in conditions where intra-abdominal pressure increases, like in case of coughing, then there will be pain which will worsen with these conditions. If you try to percuss the abdomen, the sound of the abdomen will be tympanic. You will hear a large tympanic sound, a sound which keeps on echoing in the abdomen. That is called as a tympanic sound. And we will have a distended abdomen, which is indicative of collection of flatus in the abdomen, specifically in the intestine. So we will have a tympanic sound and a distended abdomen. We will see that there are, like in small bowel obstruction, in the initial stage there is hyperactive bowel sounds which will disappear in the late stages of obstruction. In early obstruction we will have hyperactive sounds, so as to, which is a body relation or the body response to relieve the obstruction. But when there is no relieving of the obstruction in late diseases, there will be, these sounds will disappear. That there will be rebound, guarding, and or rigidity of the abdomen. There certainly is nausea and vomiting. And if you go for a per rectal examination, there will be empty rectum because of the abdominal, because of the large bowel obstruction. So the stools will not come into the rectum and you won't be able to palpate the stools in the rectum. Then there is one another pathology of the GI tract which causes obstruction, that is known as the volvulus. So in case of volvulus, the pain usually manifests as a notable transition to an inconsolable state. There is severe pain. Do what you want. The child is not going to keep quiet. The child is not going to stop crying. The child will not be relieved and it will keep on crying continuously. The pain is diffuse. It can be felt all over the abdomen. There will be severe distension and tenderness of the abdomen. There will be faint or no bowel sounds. Because of the volvulus, there will be no bowel sounds. Volvulus is something rotation at a specific axis. Remember that. So there will be multiple obstructions in volvulus. Then in volvulus, you are going to get a bilious vomiting, which is a cardinal symptom of duodenal obstruction secondary to midgut volvulus. So in case of volvulus in the jejunum, the duodenal part, the bile which comes in the duodenum will not be going forward. It will accumulate and it will be expelled out as a bilious vomiting, and this has to be there in volvulus. Then there will be faint or no bowel sounds. Again, as we have spoken of, there will be guarding and rebound tenderness, and there will be hematochezia, which we had seen again in Meckel's diverticulitis, that is painless passage of blood through the stools or through the rectum, that is hematochezia. So hematochezia we have seen in Meckel's diverticulitis and also in volvulus. Then we have something known as Hirschsprung's disease or a megacolon, congenital megacolon. This is diagnosed in the first few days or first few months of life, generally below the age of 6 months, and this is diagnosed by the symptom of failure to pass meconium in the first 36 hours of life. So if a child comes up with if you find a child who has not passed stools in the first 36 hours of life, it is strongly suggestive of Hirschsprung's disease. Yes, there are some other causes also, like uh, a meconium ileus, a meconium plug. In these cases also you are not going to pass the stool, or in a severely preterm child, the child may pass too late. But in a full-term child, if that child does not pass stools in the first 36 hours of life, it is suggestive of Hirschsprung's disease. Now, most of the times, Hirschsprung's disease is associated with Down syndrome. In Hirschsprung disease, along with pain in abdomen, which is diffused, where there will be no guarding and no rebound tenderness, there will be it will be associated with abdominal distension, because the stool material is going to get accumulated into the affected segment of the large bowel. So the pain in abdomen is mild to moderate. There will be no inflammation, there will be no guarding, there will be no rebound tenderness, and there will be abdominal distension. Most of the times, it is the rectal part or the sigmoid colon part which is involved in the Hirschsprung's disease, and therefore stools will go and accumulate over there, and we will find a fullness on palpation in the lower part of the or in the left lower quadrant of the abdomen. We might even feel a palpable fecal mass on abdominal examination because of excess of stools in that area. And because the stools collect in the uh, upper rectum or in the sigmoid colon, the lower rectum would be empty and we won't feel any stools in that area. Then these were the diseases where we had the childhood related in that. If in case of neonates we go, then there is one disease where the child might feel or is feeling but unable to express pain in abdomen, and that is necrotizing enterocolitis. Now this necrotizing enterocolitis is certainly going to happen only in preterm infants. If the child is full term, then necrotizing enterocolitis is possible only with septicemia, otherwise no. So in necrotizing enterocolitis is invariably a preterm neonate. Abdominal distension is there and there will be tenderness of the abdomen. There will be abdominal wall erythema. There will be stool with blood. There will be hematochezia. The stools which are passed, they will be painless. The child will also show signs of sepsis, like there will be and shock, like there will be apneic spells, there will be bradycardia, there will be delayed capillary refill time. All these signs of sepsis will be seen, and the child will be, or the neonate will be, lethargic. Now going back to some diseases which are not common in children but might be present. One of them is the peptic ulcer. Peptic ulcer is very much uncommon in children, and if you suspect the child that this child has got peptic ulcer and the pain in abdomen is because of peptic ulcer, then most of the cases would give you a history of pain in abdomen, give you a family history of peptic ulcer disease running in the family. Because of peptic ulcer disease, the child will refuse to feed because the pain worsens on ingestion of food, and there will be, because of less intake of food, there will be weight loss of the child, or the child will not gain adequate weight. Because of peptic disease, the pain in abdomen, it will be associated with vomiting and anorexia and refusal to feed. There will be intermittent, this pain will be epigastric, intermittent, and there will be tenderness in the epigastric region, which is usually related to eating meals. That means the pain will appear once you have meals, and the more of the times the meals pass off the stomach, they empty the stomach, then there will be less of pain, because in these cases what happens is the eating of food will lead to excessive secretion of acid, and that will cause gastritis and that will cause pain. So more of the pain is felt when you eat food, and when gastric emptying occurs the pain is relieved. So there will be intermittent gastric pain and tenderness usually related to eating meals. Pain is often nocturnal and usually relieved by antacids. Means nocturnal means at night. So once you have food and you sleep, at that time you might not, but you might wake up or the child might wake up in the middle of the night with severe pain in abdomen, because by that time the food has been partially emptied and partially present. And if you try that, that will be relieved by antacids. There will be melena and hematemesis. Then there is irritable bowel syndrome. Abdominal pain is at least 4 days per month associated with one or more of the following symptoms. This pain will be related to defecation. This will be associated also with change in stool frequency and change in stool form. So, if anything is there of these things, there is change in stool frequency, the child has started passing continuous too many stools, or it has stopped passing stools, or there is continuous passage of unformed stools, or there is continuous constipated stools for a continuous 4 days period, and that occurs every month, then we would say that this child might be having irritable bowel syndrome. In children with constipation, the pain does not resolve with resolution of constipation. In constipation disease, we had seen that once the stools are passed, the child becomes comfortable. But in irritable bowel syndrome, even though in case of constipation, if the child passes stools, the pain in abdomen will not be relieved, it will persist even after that. If these symptoms are present for 4 continuous days, at least every month, then we would diagnose it as irritable bowel syndrome. Then we have Crohn's disease, which is not again very much common with children. The pain in abdomen is crampy like we had in gastroenteritis. There is a family history of inflammatory bowel disease. There will be intermittent diarrhea. The stools are bloody if it is associated with colitis. Crohn's disease does not come up with blood, but yes, blood might be present if there is associated colitis in Crohn's disease. Because of this again, Crohn's disease is something related, something similar to that of inflammatory bowel syndrome. So there is going to be weight loss, there is going to be fatigue. Yes, one more very specific thing which we had not seen in any other diseases, that is presence of aphthous ulcers in a child, frequent aphthous ulcers in a child with abdominal pain. So once in your OPD, if some child comes up with aphthous ulcers, we are going to ask the child about the bowel habits, and we should keep in mind that Crohn's disease might present as aphthous ulcers. There is abdominal tenderness, and abdominal mass may or may not be present. Perianal fistula, abscesses, anal fissure, perianal skin tags, they are seen in the Crohn's disease. Ulcerative colitis, it is common below the age group of 10 years. The child certainly gives you a family history of ulcerative colitis. Similar to that of Crohn's disease, there will be cramping abdominal pain and there will be bloody diarrhea. This blood mixed diarrhea is usually the presenting symptom. The parents are worried that the child has passed stools Along with blood, the blood was too much, and at that time, the child was having severe pain in the abdomen, with severe cramps in the abdomen. One should suspect of ulcerative colitis. Because of loss of blood, there will be notable weight loss. Because of loss of blood, there will be notable pallor, and there will be anemia in that child. There are cramps in the abdomen, there will be abdominal tenderness, and if all these symptoms are associated with a very non-specific, non-related symptom of iritis, then in that case, one should say or one should remember that there is ulcerative colitis. So, a non-related iritis should arise a suspicion of ulcerative colitis in the child. Then we have celiac disease. Recurrent abdomen, there is recurrent cramp type of abdominal pain and distension of the abdomen. Celiac disease comes up because of allergies. Most of it is a genetic disorder, but it can be, it gets presented with some allergen, precipitated because of some allergen. And in case of celiac disease, you have cramps, you have distension and recurrent abdominal pain, you have bloating and diarrhea, you have some specific skin conditions known as dermatitis herpetiformis, which is an intensely pruritic papillovesicular vesicular rash that affects the extensor surface of the limbs. Because of celiac disease, which is an inflammatory disease, the nutrition cannot be uptaken by the child, and therefore the child will be underweight and there will be failure to thrive in the child. As I have already said, that this is triggered by dietary gluten peptides found in wheat, rye, barley, and similar grains. So celiac disease is a allergic disorder. It is a basically genetic disorder precipitated by allergies to of some food which contain gluten. So these were the causes where we had abdominal pain related to the GI tract. Now going for abdominal pain which come up because of diseases or because of pathologies present in the abdomen, but which are not because of the GI tract. So that will be considered all under other abdominal causes. Common one is the mesenteric adenitis. The mesenteric lymph nodes, they get enlarged, and that is called as mesenteric adenitis. In case of mesenteric adenitis, there will be diffused abdominal pain, there will be abdominal tenderness which is not localized to any of the specific quadrant of the abdomen. Sometimes it might be in one quadrant, sometimes it might be in the another quadrant. There will be shifting of point of maximum tenderness when a child turns. So when at the time of inspection or the time of palpation, we have a tenderness in the right abdomen, right quadrant or the right abdominal area. When the child turns, it might be felt in the lower left quadrant or in the umbilical area or the lower lumbar region or the left lumbar region also. Shifting of the point of maximum tenderness on when the child turns, there is likely to be, the child might likely to be having a high grade fever and dysuria and are less likely to have migratory pain, vomiting or typical abdominal signs of appendicitis. History of recent or upper or current upper respiratory tract is present where that infection is curtailed to the local lymph nodes, and from there the infective organisms through the lymphatics might drain into the mesenteric lymph nodes. So that will cause adenitis, and that will then adenitis will lead to pain in abdomen. There will be associated extramesenteric lymphadenopathy. Generally, that is the cervical lymph nodes will be affected. Along with cervical lymph node, you might get the submandibular and lymph nodes and the posterior cervical lymph nodes. The supraauricular lymph nodes also might be enlarged and inflamed. Then we have acute peritonitis. In case of acute peritonitis, like that of appendicitis, there will be severe abdominal pain, but in appendicitis, the pain was located, or it could be located and pinpointed out. It was limited to one area. In case of acute peritonitis, there is diffused pain all over the abdomen. The intensity is the same. There will be severe abdominal pain. There will be diffused rebound tenderness and abdominal rigidity. The child will not allow you to palpate or even touch the abdomen because of severe pain. Even if you try to palpate the abdomen will be duffy. You prepare a dough and to prepare bread, and you try to press it or you try to touch it, the same feeling will be seen when you palpate the abdomen when a child has got peritonitis. There will be severe distension. There will be sluggish or absent peristaltic sound because of septicemia. There will be pyrexia, and the child will be into or will have a toxic look. Acute peritonitis is an acute emergency, and if these signs are basically the appearance of abdomen which is tender, which is distended, which is shiny, and the toxic look of the child will give you an insight of acute peritonitis. It would be an mostly a spot diagnosis. Then we have something related to the liver, the cholelithiasis and the cholecystitis. The gallbladder is involved in this. We are going to have biliary colic. It is not just plain abdominal pain, but we will be having biliary colic in cholelithiasis and cholecystitis. Now, what is biliary colic? It is an intermittent, recurrent, episodic right upper quadrant pain that resolves without intervention. So, there will be right upper quadrant pain, but without any treatment, it will subside after some time and again re-come up after some time. So it will be intermittent, recurrent and episodic pain in the right upper quadrant. This pain may radiate up to the right shoulder and the back. And when it radiates, it's classically colicky. It often occurs after eating, and specifically when you eat fatty foods. The fatty foods are a impulse for the secretion of cholecystokinin, which is responsible for the constriction of the gallbladder, and this gallbladder constriction will lead to release of bile into the duodenum. And when you eat fatty food, the inflamed gallbladder will be compressed or will be squeezed, which will cause severe pain in abdomen. So fatty food eating with when it causes pain in abdomen in the right side, one should think of cholecystitis. There will be often there will be associated anorexia, nausea and vomiting. Then there will be persistent pain and fever, and this may signify acute cholecystitis. You will feel subcostal tenderness in the right area, and you will have a positive Murphy's sign, that is during palpation or during deep inspiration you will have pain and which will become suddenly worse and might produce inspiratory arrest. So positive Murphy's sign, that is when you deep breathe or when you palpate in the right side, you are going to get pain. This is present in cholecystitis. Then we have viral hepatitis, where we get the pain is diffused, it is not localized, and you get a history of infected water injection, of unclean water ingestion, or going into an endemic area, or eating infected food. In the early disease, there will be malaise, muscle and joint aches, fever, nausea, vomiting, diarrhea, anorexia. Invariably, you are going to have dark urine and tender hepatosplenomegaly, whereas in late viral hepatitis, you will have weight loss and bleeding tendencies. But the pain in abdomen will be moderate and diffused. Then we have liver abscesses and the subphrenic abscesses. The pain is generally in the right upper quadrant, right hypochondriac region, what we call it as, and is generally referred to the right shoulder. So when you have pain in the right upper quadrant or the right hypochondrium, referring pain to the right shoulder, think of phrenic abscesses, think of liver abscesses, think of cholecystitis, think of hepatitis. You are going to have hepatic tenderness also. There will be hepatomegaly. There will be, because of the presence of abscess, there will be sepsis. So the child will have toxic looks, and because of sepsis, the child might be having high grade fever. Basically, subphrenic abscess, they do not form on their own. The abscess is in the liver, and the hepatic abscess might burst out, and the pus might collect above the liver below the diaphragm, creating a subphrenic abscess of the same side, and the liver and the pain is referred to the same side shoulder. Acute pancreatitis is another place where we have pain in abdomen. It is very uncommon in children. The pain will have an acute onset of abdominal pain. The child will be having an acute onset of abdominal pain, and this pain is typically epigastric and radiating to the back. It will arise, or it will start in the epigastric region, typically below the xiphisternum, and it will go sharp like a stabbing pain to the back. There will be epigastric or upper abdominal tenderness and tachycardia will be present. The patient or the child is invariably in hypotension, and there will be something known as positive Cullen's sign. The Cullen's sign is discoloration or paleness around the umbilicus. There will be, or there might be, another sign present, that is known as the Gray Turner sign, where you get change in color of the skin in the flanks. So Cullen sign and positive Gray Turner sign might be present in acute pancreatitis. There is abdominal distension, nausea and vomiting, but the character of the pain is stabbing pain arising in the epigastric area just below the xiphisternum and radiating it to the back. Then in abdominal trauma, this might be a blood trauma or a sharp trauma. The child will have pain in abdomen of various intensity. It might be a mild pain, it might be a sharp pain, depending upon the intensity and the magnitude of trauma. So the child will have varying type of pain. Pain will be out of proportion to findings on physical examination. The child might say that there is severe pain, but on physical examination you will not find a specific pathology. There will be abdominal tenderness or guarding at the site of trauma. The referred pain At the site of the right shoulder will indicate pain or trauma to the liver, and on the left will indicate the trauma to the spleen. On examination, you might find marks of injury. If it is in the flanks, you might get hematuria, and the child will give you a history of trauma. So these were the diseases related to the GI tract and other abdominal organs where we have abdominal pain. There are other causes of abdominal pain which are not related to the directly to the abdominal organs or to the GI tract, and which arise with pain in abdomen. We will have a look at it in the next part of the lecture. Thank you.